The People's Pharmacy podcast is sponsored by the Brain Gauge, developed by neuroscientists at the University of North Carolina to study brain function across a wide range of applications, including aging and traumatic brain injury. The Brain Gauge translates state-of-the-art neuroscience into easy-to-use methods that let you take control of your brain health. Now available with a low-cost subscription model for the home. Find out more at gaugeyourbrain.com. Chronic heartburn can lead to a condition called Barrett's esophagus. It's linked to esophageal cancer. How great is the risk? This is the People's Pharmacy with Terry and Joe Graydon.
Have you ever had a colonoscopy? This screening procedure for colon cancer saves lives, but a lot of people are squeamish about it. People with Barrett's esophagus also need upper GI endoscopy. How often should these procedures be repeated?
An ancient Chinese remedy for severe diarrhea is being resurrected. Fecal transplants are a powerful tool against C. diff infections that cause intractable diarrhea. How do we get past the yuck factor?
Coming up on the People's Pharmacy, learn about new ways to heal your digestive tract.
First, the news.
In the People's Pharmacy Health Headlines, probiotics have been gaining a reputation as a way to treat a wide variety of digestive upsets. Many of the studies to back up this recommendation have been small or not well done. Now, a careful placebo-controlled trial in young children found that Lactobacillus rhamnosus, GG, was no better than placebo in halting diarrhea and vomiting. There were 943 children in the study. Half were younger than 1.5 years old. These children were brought to one of 10 pediatric emergency departments and given a 5-day course of the probiotic or placebo. There was no difference in days missed from daycare, duration of symptoms, or likelihood of spreading the illness to others in the household. A similar trial in Canada arrived at the same conclusion. Probiotics have been shown to be effective for other problems, including C. diff, but they don't appear to offer any advantages for this common childhood illness.
Do you answer a doctor's questions truthfully? If so, you are unusual. A new study published in JAMA Network Open suggests that anywhere from 60 to 80% of patients are not always honest when answering questions from their physicians. Investigators surveyed over 2,000 middle-aged people and 2,500 older patients. The participants were offered 7 hypothetical scenarios and asked if something like this had happened to them, how they responded, and why. Younger women were least likely to be truthful about important medical information. Many volunteers admitted to fibbing about diet and exercise. They worried that the doctor would think less of them or scold them if they told the truth. Others were embarrassed to admit that they disagreed with a prescription or a recommendation. If doctors don't know what a patient is doing or not doing, it could impact treatment outcomes. The authors suggest that physicians should be trained to help patients feel more comfortable about telling the truth.
Chronic sleep problems have been linked to diabetes, weight gain, high blood pressure, forgetfulness, accidents, lowered immunity, and delayed reaction times. Now add grumpiness to the list of consequences of insomnia. Researchers at Iowa State University recruited volunteers who either got their regular amount of sleep each night or reduced their sleep time by 2 to 4 hours for 2 nights. These participants came to the lab and were subjected to annoying sounds on headphones while they rated different products. Those who had slept less were quicker to get angry. The scientists are now evaluating whether sleep loss also contributes to aggression.
Clostridium difficile, or C. diff, was once considered a hospital-based infection. The bacterium was discovered as part of the normal intestinal flora in 1935. Shortly after that, doctors found that some patients developed severe diarrhea in reaction to antibiotic treatment. It wasn't until 1974 that scientists identified C. diff overgrowth as the culprit in such cases. Clostridium can make spores that resist disinfection, making it a serious problem in nursing homes and hospitals. Now, however, C. diff is causing trouble everywhere. The CDC counted approximately 350,000 C. diff infections in 2011. Nearly half of them had no connection to hospitals, and more than one-third were not preceded by antibiotic use. In 2017, California researchers found that 10% of emergency room patients with diarrhea had C. diff. Researchers speculate that changes in the microbiome may be making us more susceptible to this opportunistic infection.
New results from the National Survey of Children's Health reveals that roughly 1 in 40 American youngsters has been diagnosed with autism. There were 43,000 children between the ages of 3 and 17 covered by the survey. The new data show a higher incidence of autism than the CDC uncovered from a different data set. That research indicated 1 child in 59 is on the autism spectrum. Regardless of the actual exact incidence, experts say that autism spectrum disorder is common, and early screening and treatment are more important than ever. That's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. Americans invented the drive-through for fast food. We eat on the run, and what we eat is often highly processed. We're also in a lot of pain, so we pop drugs like Advil, Aleve, or Motrin IB. Between our diets and our drugs, we're hard on our digestive tracts.
It's little wonder that heartburn is so common. Drugs to control it, from antacids like Tums to proton pump inhibitors like Nexium or Prilosec, are big sellers. But is that the best approach for our digestive woes?
To help us understand what we need to do to heal our digestive tracts, we turn to Dr. Nicholas Shaheen. He's the Bozimsky-Heiser Distinguished Professor of Medicine at the University of North Carolina School of Medicine. He's chief of the Division of Gastroenterology and Hepatology.
Welcome back to the People's Pharmacy, Dr. Nick Shaheen.
Thank you, Terry. It's a pleasure to be here.
Dr. Shaheen, you've written a fascinating article titled Less is More, a Minimalist Approach to Endoscopy. First, what is endoscopy, and why is less more?
Endoscopy is the procedure by which we look inside your body, your GI tract, for abnormalities, and we use it quite often. In fact, as you probably know, Americans are recommended to have routine endoscopy for colon cancer screening starting at age 50.
You call that a colonoscopy?
That would be a colonoscopy, that's correct.
And you also come down from the top?
I do mostly from the top, that's correct. That's called upper endoscopy.
And you look at people's esophagus. How do you pronounce a plural esophagus?
Esophagi.
Okay, so
Yes.
they're checking your pipe, and they're looking at the stomach.
At the stomach as well.
And you can even
correct.
get into the small intestine.
That's right. You've got 22 feet of small intestine, so we can't see it all, but we can see the first few feet, which is very helpful for diagnosing various conditions.
So we keep hearing, go get a colonoscopy. It will save your life. It can prevent colon cancer, a very common cancer.
A lot of people like to ignore that advice.
Let me start by saying, go get colonoscopy. It'll save your life. That's
Right.
I don't want people to leave this segment thinking that colonoscopy is not a vitally useful medical procedure or that it's not effective in averting death from colorectal cancer, because those are both very true. This is a preventable cancer. People should go talk to their primary care doc about it, and if it's appropriate for them, they should be sent for colonoscopy.
But
no pun intended. There is, for certain indications and certain procedures, an overutilization of endoscopy. Let me give you an example. So let's say you do go in for that screening colonoscopy, and during that screening colonoscopy, we find a polyp or precancerous condition of the colon that we then remove.
Right. I mean, that's the standard procedure. If you find a polyp, it comes out.
Exactly. And that's actually a good thing, because that'll decrease the risk that you'll get cancer. You remove precancerous tissue, which is exactly what we wanted to do. However, you've also declared yourself at being at increased risk for getting another one of these polyps or precancerous conditions.
Because if you made one, you'll make another one.
Exactly. So we tell you need to come back and see us again. Okay? And the interval at which we tell you need to come back and get your second colonoscopy actually depends on the findings of your first colonoscopy. If your first colonoscopy has no polyps, you're good for 10 years. You're off the hook. We aren't going to see you again until age 60, assuming that you came in at age 50. And that's terrific because there's obviously a little hassle and expense that goes into colonoscopy. On the other hand, let's say that you have a pretty decent-sized polyp, say something the size of a kid's marble, and we take it out of you. Now, if that polyp shows us certain characteristics, we may tell you, we need you back sooner. We're worried about you. We want you to come back at 3 years, or we want you to come back at 5 years. What we find when we look at the data is that unfortunately sometimes people get the wrong guidance. And the wrong guidance often comes in the form of being told to come back too soon. We're being conservative is what the doctors will say. Well, the usual recommendation for this might be 5 years, but let's be conservative and have you come back in 3 years. Conservative is a catch term.
Conservative is kind of a funny term in this context.
Thank you. That's exactly right. So we can lead to overutilization. Too often our patients consider more medicine to be better medicine. So, gosh, my doctor cares so much about me that they want to do colonoscopy on me every year.
Whoa.
Now, colonoscopies are expensive.
Colonoscopies are somewhat expensive. Now, there's expense overall, an expense that goes to the patient or the copay. So both can be quite high numbers. It's not unusual for a regular colonoscopy to cost in excess of $1,000. And maybe, depending on obviously your insurance, a substantial proportion of that may devolve to the patient. Maybe $200, $250. It's not inconsiderable. And even more important than that, perhaps, is each one of these exams also has some risk and some side effects associated with it. Now, granted, those risks are relatively low. However, in the aggregate, if we're doing a lot of endoscopy that doesn't need to be done, we're going to rack up some problems for our patients.
What kind of risks are they?
Sure. Well, there are certain things that happen rarely but are potentially really problematic. For instance, perforation or making a hole in the colon.
That would be very bad.
That would be bad, and that can oftentimes necessitate surgery to remove the piece of colon where the hole was made. So that's clearly something that we're trying to avoid when we're doing those procedures. Other more mundane things, if we do take out a polyp, or even if we don't take out a polyp, there's a risk of bleeding, because we're rubbing that endoscope against the lining of your colon, or potentially we're biopsying it or removing polyps. So there's a risk of bleeding with those exams as well.
So in order to get the balance just right, you want to find the sweet spot. You want to see somebody often enough that they don't develop a huge colon cancer in between time, but not so often that you're putting them at unnecessary risk. How the heck do you manage that?
That's exactly right, and that's what we're shooting to do. We have a limited amount of natural history data about what happens with a polyp and how long it takes a polyp to move on to a cancer. We also have a lot of data of populations that have undergone colonoscopy and what happened to them between the colonoscopies. And using these two groups of data, professional organizations and experts have come up with suggested intervals that are in guidelines. The doctor doesn't need to make this up or do an in-depth review of the literature every time they see a patient. Our organizations, our professional organizations, have made it easy on them. Essentially, there's a chart to say if we find this, the suggested follow-up for it is this. If we find that, the suggested follow-up is that. So adhering to those guidelines, which are based on our best evidence, should give you the maximal bang for the buck. You should get the adequate coverage to keep you from being one of those folks that develops the big cancer you just described. But also, you shouldn't be coming so often that you're really taking on needless endoscopy and extra procedures and extra risk for really marginal benefit. So that's what we're trying to do with those guidelines.
Dr. Shaheen, you focus on the upper end of the gastrointestinal tract. So you're doing, as you called it, upper endoscopy. You're looking at the esophagus. And sometimes people who have really bad gastro-esophageal reflux disease, they call that GERD, and you can tell us what that actually means, they get some abnormal cells at the bottom of the esophagus, and you detect them. Once that happens, it's called
Barrett's esophagus.
And people are told, come back.
Right. So in a lot of ways, this is analogous to the situation we were just discussing, except instead of going after polyps, we're now going after this precancerous tissue. But the clinical proposition is pretty much the same. So you've got this condition in your body that puts you at some increased risk for cancer, and we can talk about that risk. It's actually not that high, but there is an increased risk. And we're doing the same balancing. We're asking, how often should we do endoscopy to look at this condition and take samples to make sure it's not progressing? We want to do that often enough to avoid the situation where we have an advanced cancer, but not so often that we're needlessly exposing the patient to the risks of the endoscopy.
In addition, an endoscopy is not necessarily a delightful procedure, right?
Well, it's not something you would do for fun, let's put it that way.
Right.
But I don't want folks to come away from this thinking that it's a horrible procedure that will emotionally scar them for life.
Right.
Nowadays, we have very good sedation medicine. These tests are done very expertly in most centers. And frankly, to be honest with you, for most folks, it's a nice sleep and then a wake-up.
Well, I've had this experience, and I have to tell you, it was just about a walk in the park. I went to sleep. I woke up. It was done. And I didn't feel any discomfort whatsoever. So the question is, if you have Barrett's esophagus, and a lot of people do, how often do you have to come back to be checked?
Great question. So the first point, a lot of people do. 1% to 2% of Americans actually have Barrett's esophagus. If you've had heartburn for a long period of time, talk to your primary care doctor about whether or not you should have screening. So that's one point I want to leave. If you do happen to be in that group that has Barrett's, and like I said, a lot of people have it, you're looking at coming back for most folks on a 3 to 5 year interval. Those are our current recommendations. And the rationale for that is that we think that it takes Barrett's probably somewhere in the neighborhood of 7 to 10 years to go from non-dysplastic or no precancerous changes in that small subgroup who is going to progress on to cancer. So we're going to have a couple of chances to catch that before it's become a full-blown cancer that we can't take care of.
And this is what? An esophageal cancer?
That's correct. This would be an esophageal.
And that's a nasty cancer, hard to treat. And we'll talk after the break a little bit about your technology and how you have revolutionized the treatment of precancerous lesions. But it is important for people who have chronic heartburn to be checked for that very reason.
Exactly. So unfortunately, this cancer most often shows up when it's the size of your fist.
Aye.
And at that point, as you can imagine, our treatment options are low, the cancer is advanced, and unfortunately, the vast majority of folks that are in that condition are going to have problems.
So that's why the screening is important.
You're listening to Dr. Nicholas Shaheen, the Bozimsky-Heiser Distinguished Professor of Medicine at the University of North Carolina School of Medicine. He's chief of the Division of Gastroenterology and Hepatology. Dr. Shaheen is a recognized expert in esophageal diseases and endoscopy. He's the author of multiple treatment guidelines for gastrointestinal illnesses.
After this break, we'll talk more about esophageal cancer and how it can be detected early.
How can early esophageal cancer be treated effectively?
What is the role of your immune system?
How often should people be screened to detect cancer in a timely fashion? And what can you do for heartburn symptoms?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
The People's Pharmacy podcast is sponsored in part by Kaya Biotics. Kaya Biotics offers the first probiotics which are both certified organic and hypoallergenic.
All probiotics are produced in Germany under laboratory conditions with high-quality ingredients and under strict regulatory oversight.
The 3 available formulas are created for very specific purposes, such as strengthening the immune system, fighting yeast infections, and helping with weight loss.
To learn more about Kaya Biotics probiotics and the important topic of gut health, you can visit their website, KayaBiotics.com. That's Kaya Biotics.com. Use the discount code PEOPLE for $10 off your first purchase. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. If you would like to purchase a CD of this show, you can call 800-732-2334. Today's show is 1144. That number again, 800-732-2334, or you can visit our website, peoplespharmacy.com. You can also download the podcast from iTunes.
The People's Pharmacy is brought to you in part by Brain Gauge, developed by neuroscientists at the University of North Carolina to track brain health. Home, research, and clinical applications available. Home subscription options are available online, gaugeyourbrain.com.
Today, we're considering problems that affect our digestive systems. Are there new ways to combat them?
Our guest is Dr. Nicholas Shaheen, the Bozimsky-Heiser Distinguished Professor of Medicine at the University of North Carolina School of Medicine. He's chief of the Division of Gastroenterology and Hepatology.
We've sadly had the experience, Dr. Shaheen, of losing friends, dear friends, from esophageal cancer. And it's nasty. So tell us a little bit more about it and why our treatments, for the most part, haven't been very good until fairly recently.
So your esophagus runs through a very high-priced piece of real estate in your body. And by that I mean, if you think about the way it courses down from your mouth through your chest into your abdomen, you're going right between the lungs, you're going right next to the heart. So it's not surprising that a cancer growing in that area is going to have some nasty ramifications for things like direct extension into other organs. The most common way this cancer shows up is someone's eating and they go, my gosh, that just got stuck. I just ate a hot dog. Maybe I didn't chew it well enough. It got stuck in my chest. Or I ate some chicken or some bread. That's a very common story. And then they'll put up with it a little while and maybe think that it was just bad luck or not chewing well enough. But eventually they'll mention it to a doc. And then they'll get sent for an upper endoscopy. And that, unfortunately, is when we find the majority of these cancers. Greater than 90% of them are not found the way I just discussed with you by way of screening, but are actually found after the patient's symptomatic. The bad news is that once the patient is symptomatic, almost always that cancer is pretty advanced. And our options for getting rid of it are small. We'll try to take it out surgically. Perhaps we'll try chemotherapy and radiation. But the upshot of it is that, unfortunately, in most cases, we're unable to cure that patient.
But if caught early enough, you can cure patients or at least create conditions that are much, much more positive. Tell us about your research.
That's exactly right. If you happen to be lucky enough to find one of these cancers early in the course, it's a totally different ballgame. Many times, such a cancer can actually be removed internally through your mouth by endoscopy, and you'll never even have to go through this relatively large surgery, the esophagectomy, or removal of the esophagus, which is a very difficult surgery to go through. So what we've been concentrating at our center and at several other centers in the country for the last 10 or 15 years are less invasive ways of treating these early cancers. Now, if you come to see me and your cancer is as big as your fist, I've still got the same options we had essentially 15 or 20 years ago. We're talking surgery, chemotherapy, or radiation. That's all we have. However, if you come to see me and that cancer is, say, the size of a pea or the size of even a small marble, there's a very good chance that we're going to be able to go down using new tools and remove that cancer from the inside while leaving the rest of the organ in place. And this treatment is associated with cure rates that are greater than 90%, as opposed to that 80% mortality at 5 years that I told you for the advanced cancers. We're talking about the vast majority of people doing very well with these treatments.
So what kind of treatment is it?
Sure. So the first thing we do is, for the cancer proper, we do a removal, and that removal goes by the name of endoscopic mucosal resection or endoscopic submucosal dissection. They're both sexy terms, which essentially just mean that from the inside we lift that cancer out and we scooped it out. Now, that's all we used to do, but then we found that if we left the person otherwise the same as they were before, another cancer would grow up. That's a bad thing. So because we may not catch the second one like we caught the first one. So we give a second treatment, which is called an ablative treatment, to get rid of that fertile field where the cancer grew and to turn that back to normal covering of the esophagus. And that's one of the areas that we're quite interested in. And we've developed with our partners over the years a lot of different kinds of techniques for trying to develop normal epithelium there. But the bottom line is that we kill the abnormal stuff either by heating it, freezing it, or somehow insulting it and let normal, healthy tissue grow back.
Does the immune system have a place in this process?
That's an interesting question. It's one that we're really interested in. We think that if you freeze cancer cells and cause them to burst, which is what they do when they freeze, perhaps they release antigens that actually make the immune system help us clear the cancer. And there's a pretty substantial body of literature that now suggests that the immune system is pretty important in the healing of cancers, and this may be another incidence of that.
So in order to find a cancer of this type early enough to be able to use your ablative techniques, you do need to be screening people.
Exactly.
So the mystery then is, how often is the right amount of time?
Sure. So we occasionally get lucky that someone will present symptomatically and still have a cancer that we can cure internally. But you're absolutely right. The vast majority of these cancers that are curable by this less invasive therapy come from screening programs. And these are some general guidelines. If you're greater than the age of 50, if you're male, if you're overweight, if you've had reflux symptoms for greater than 5 years, all those are risk factors for that precancerous condition, the Barrett's esophagus that we were discussing. So if you fit even a couple of those, you're going to want to mention to your PCP that, hey, I'm having some reflux symptoms. Now, if you're a 25-year-old Asian woman, your risk of this cancer is extremely, extremely low. The lifetime risk of this cancer is very low. But if you have some of those other risk factors, then you're definitely in the sweet spot for thinking about screening. If you get a screen and that screen is negative, you're done. You don't have to do it again. It's not like colon cancer screening, because it turns out if you're going to get this Barrett's esophagus, you get it early in your life. On the other hand, if you got the Barrett's, that's when you need the serial exams. You need to come back every 3 to 5 years to be watched.
All right. So you told us that Barrett's esophagus means that you have a higher risk of developing this cancer, but you said the risk isn't quite as high as people have been led to believe. Give us a little bit more idea about this, please.
I'm glad you asked that, because unfortunately, many patients, when they hear you've got a precancerous condition of your esophagus, all they hear is the big C word, and then they're done.
Exactly. And some patients tell us whether or not this is what their doctor says or this is what the patient hears. Some patients tell us, my doctor says I have Barrett's, and if I don't do X, Y, Z, I will get cancer.
And that usually XYZ includes a proton pump inhibitor. So you will take Nexium for the rest of your life, or you will get esophageal cancer and you'll die.
Right. So let's talk statistics first. If you take 1,000 patients with Barrett's esophagus and you watch them for a year, you can expect from that group somewhere in the neighborhood of 3 patients to get this cancer.
Okay, so that's 3 per 1,000 person years.
3 per 1,000 person years is the risk in a Barrett's population. So quite low, actually, in any given year. Not zero, so we want to take care of this, right? But certainly not high enough that any sentence should end with, you will get cancer, right? So the vast majority of patients with Barrett's, and I want this to come out unequivocally, will not die of esophageal cancer. This is not a death sentence. You're less rather than more likely to get it. This is just one of those things that you want to keep an eye on and take care of like anything else. So you should not feel that this is some immutable trail that you're on that you're headed toward cancer, because that's not the truth. This business about proton pump inhibitors is one that we should talk about because it's really important.
And controversial.
And in the media more and more and more. This is what you need to know. There are multiple retrospective studies that suggest that patients with Barrett's esophagus who are getting acid suppression, most commonly with a proton pump inhibitor, have a decreased risk of progressing onto precancerous and cancerous changes in their Barrett's. There is some of that data. So we do recommend that folks be on one of these medications a day. If 1 is good, 2 is not necessarily better, nor is 3. So you don't need to be piling this up. You also don't need it if you've had a surgical correction, so you're not having reflux, the so-called fundoplication, okay? But in the absence of those things, for the average risk individual, we do suggest that they probably be on some acid suppression. Lots of studies about that. The upshot of it is in these patients, for most of these patients, we think that the benefits outweigh the risks.
Now, what about other ways of suppressing acid? Because we do have what are called the H2 antagonists, drugs like Zantac, for example, Pepcid. I mean, there are a whole bunch out there. And, of course, there are antacids. And actually, this brings up the whole question, what causes Barrett's? Is it acid? Is it other stuff in your stomach? And are there ways to prevent GERD, so that it doesn't cause so much damage?
Great. So let's start with your second question first, which is what causes Barrett's. We know that Barrett's is associated with long-term heartburn. But let's talk about heartburn for a second, because everybody thinks they have heartburn. Any ache between people's chin and their knees will variously be described as heartburn by somebody. Real heartburn is a warm or burning sensation that starts in what we would consider the pit of our stomach, just below the breastbone, and rises up toward our throat underneath our breastbone. That's classic heartburn, and that's really what we're talking about. If you've had that and you've had that for years, that is associated with Barrett's esophagus, and that's really what we're looking for. And we think it's because the acid has done damage to the internal lining of the esophagus. Now, as to the second question, what about H2 blockers? This is what we know. H2 blockers are good medicines for decreasing acid, but there's a couple caveats. They're not as strong as a class as proton pump inhibitors. And the second thing, which I think may be underappreciated, is that they oftentimes become less effective the longer people use them. There's this so-called tachyphylaxis phenomenon, meaning that the more you take it, the less effective it is. So it's terrific for episodic heartburn problems that people have, say, in the middle of the night you wake up. If you have a proton pump inhibitor and H2 blocker sitting on your desk in the middle of the night and you want relief that night, take the H2 blocker.
Because it'll work faster.
Right. It works faster.
Of course, so will baking soda.
So will Tums. So will any topical antacid. All that would be just fine.
So for garden variety heartburn, I had the hot dog with the sauerkraut, and then I had the beer, and then I had the pizza.
And then the ice cream shouldn't have done that.
What should we do for that kind of heartburn?
Well, that's a great question with the holidays coming up. And the answer is that there's absolutely nothing wrong with a liquid antacid for those situations. So if you're keeping some over-the-counter antacid around the house, or even if you want to use baking soda, any base will help neutralize that acid.
So you're talking like Maalox, Mylanta?
Would be fine. Any of those would be just fine. If you're doing that every night, and we've all met people who are taking a whole container of Maalox over the course of a week, then you've got a problem that you need to get more help about.
Yeah, that was my roommate in college. He had a pack of Rolaids with him everywhere he went. He went through at least 1 to 2 every day. And that continued through adulthood.
Until he developed esophageal cancer and died.
Yeah, and it was really tough. So pay attention. I think that's one of the messages today is if you have frequent heartburn, if it goes up your chest, see a doctor, perhaps an upper endoscopy, because we spend so much time talking about get your colonoscopy. We don't hear the same message about upper endoscopy, and yet that could prevent esophageal cancer for a lot of people, just as colon cancer is prevented through colonoscopy.
That's exactly right. And one message I want your listeners to take home is that this cancer has gone up 500%
What?
in incidence since 1975.
Wow.
So this is an important message, and it's even more important now than it was 15 years ago.
Do we have any idea why?
Terrific question. The short answer is we don't know for sure. One thing that we do know is that this does parallel the epidemic of obesity in the United States. So one very reasonable hypothesis is that at least some of this increase is probably associated with the increased incidence of reflux that comes along with obesity. We know that people that are obese are more likely to have reflux, so more reflux equals more Barrett's, and more Barrett's equals more cancer.
Dr. Shaheen, as you look into your crystal ball, what do you see going forward for people with reflux, for people who do have some kind of maybe esophagitis and maybe even the beginnings of Barrett's?
That's a great question, and there are some really interesting things that are happening. The medicines we use now don't stop reflux. All they do is they take the potency out of the refluxate. So if you take stomach acid and you put it in a glass and you throw a penny in the glass and you come back 3 days later, the penny will be gone. The glass will be gone too. And that's because the acidity of your stomach acid is in the pH 1 range. It's incredibly acidic. Hard to imagine that any human can tolerate that.
It is. That's incredible. How come it doesn't dissolve the stomach or the rest of you?
It's the only place in your body that is uniquely designed to take this amount of acidity. What the PPIs do, the acid suppressants that people take, all they do is they take the acidity, the caustic nature out of that fluid, but you're still refluxing. What's happening now, what's being developed, which is really interesting and still in its infancy, are ways of correcting the actual anatomic problem that's causing reflux from the inside. In the old days, our only choice was surgery to kind of tighten up the valve at the bottom of the esophagus. Now, several groups are actually experimenting with ways, minimally invasively through your mouth, of actually tightening up that area, reducing the hiatal hernia, and actually fixing the anatomic problem so that the reflux itself doesn't occur. A lot of these are still under development, but several of them are commercially available now, and they're becoming really interesting. So it'll be fun to watch this and see if perhaps, the point you made earlier, Joe, about, well, am I going to be on this medicine forever? I get that question all the time. And the answer is, well, maybe not. Maybe there's better things on the horizon.
Dr. Shaheen, you're not just focused on the esophagus. You're a gastroenterologist, which means the whole thing. One of the complications, oftentimes after very powerful antibiotics, dentists like to prescribe drugs like clindamycin, for example, that patients can react with C. diff infections. You disturb that homeostatic balance in the digestive tract. What can be done for this? Because oftentimes the antibiotics that are prescribed don't always do the job.
Yeah, that's a great question. It's one of the big problems in our business now. C. diff has become, with a vengeance, one of the worst infections that we treat of the colon. And when you think about it, what we've done for traditionally is a little bit counterintuitive. You get C. diff because we've given you antibiotics and we've killed the healthy bacteria, so this bad bacterium has grown. So what are we going to do? Well, let's give you antibiotics.
More antibiotics.
Right, which is not a happy thing. So there's got to be a better way. And in fact, people that are interested in this have actually started manipulating what's called your microbiome, which is the bacteria that live in your colon. All of us have more bacteria in our colon than there are cells in our body. There's more of them than us in our body. It's really a remarkable thing when you think about it, and probably shouldn't think about it too long. But if you do, you realize that there's this complex interaction between them and us. And by manipulating them, we actually can change us. By that, I mean we can promote health. And it's been shown in multiple places, perhaps no place better than C. diff, because we can actually repopulate that colon with healthy bacteria.
Dr. Nick Shaheen, thank you so much for talking with us on the People's Pharmacy today.
Pleasure to be here.
You've been listening to Dr. Nicholas Shaheen, the Bozimsky-Heiser Distinguished Professor of Medicine at the University of North Carolina School of Medicine. He's chief of the Division of Gastroenterology and Hepatology. Dr. Shaheen is a recognized expert in esophageal diseases and endoscopy. He's author of multiple treatment guidelines for gastrointestinal illnesses.
After the break, find out more about fecal transplants as a way to heal the digestive tract.
What is C. diff and why is it so serious?
How does the FDA see fecal transplants?
Can this treatment be helpful for any other conditions?
You're listening to The People's Pharmacy with Joe and Terry Graydon. If you're enjoying this People's Pharmacy podcast, why not head over to our website where you'll find a wealth of information on medications, conditions, home remedies, and ways to keep yourself healthy. You'll find it all at peoplespharmacy.com.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. To purchase a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1144. That number again, 800-732-2334. You can also download the free podcast from iTunes or from our web store, and we invite you to consider writing a review.
The People's Pharmacy is brought to you in part by Brain Gauge, developed by neuroscientists at the University of North Carolina to track brain health. Home, research, and clinical applications are available. Home subscription options are available online. GaugeYourBrain.com.
We were just talking with Dr. Nicholas Shaheen of the University of North Carolina about digestive difficulties, including C. diff infections. Clostridium difficile has been increasing over the last several years. It's no longer limited to healthcare facilities. It can cause dangerous, sometimes intractable diarrhea. But treating this infection with antibiotics doesn't always work. So doctors are turning to an intriguing approach called fecal transplants.
To learn more about fecal transplants, we turn now to Dr. Michael Bretthauer. He's professor of medicine at the Institute of Health and Society at the University of Oslo and the Department of Transplantation Medicine in Oslo University Hospital, Oslo, Norway. He's also president of the Frontier Science Foundation in Brookline, Massachusetts.
Welcome to the People's Pharmacy, Dr. Michael Bretthauer.
Thank you for having me. It's great to be here.
Dr. Bretthauer, you are the lead author of a study using fecal transplants to treat something very nasty called Clostridium difficile. That's a serious infection where bacteria can take over a person's intestines. First of all, can you tell us what is a fecal transplant? And number two, what is Clostridium difficile and why is it so serious?
Sure. So fecal transplant is the treatment of patients with, for example, this disease that I will explain to you in a minute, with either fresh feces from a donor, so a healthy individual, different from the patient, either fresh or frozen, or compounds or components of feces from that donor, a healthy individual, applied to that patient who is sick of this disease or other diseases, either as an enema or through a nasal tube or through a colonoscope applied to the gastrointestinal tract, the large bowel, the colon, to this patient to relieve his or her symptoms.
Now, of course, our listeners are going yuck because there's a huge yuck factor when you talk about this sort of thing. How do you sanitize this process so it doesn't seem so difficult?
Well, in the hospital we are used to work with body fluids, so this is, and I agree, it doesn't sound particular interesting with regard to any pleasure or something like that, but it is. These patients, you have to remember, are very sick, and what we found and other people found in studies is that by establishing the healthy flora, so normal healthy bacteria in the colon, you can actually help these people to get symptom relief much quicker than we used to do before. And thus these patients, they are in need of treatment. And in that situation, you are, I think, willing to do this. And usually if we do this by the methods I just described, either during a colonoscopy where the patient usually would be asleep or sedated at least, or through an enema, this is usually not a problem for patients. And we asked them afterwards if this was something they would like to do again, if they need it, of course. The vast majority of people say, well, this is not as bad as I thought it would be.
Dr. Bretthauer, you were about to explain to us what is Clostridium difficile and why is it such a problem?
So Clostridium difficile is an interesting bacterium. We like to call it C. diff, which is shorter than the full name. So C. diff is a bacterium which many of us have, as healthy individuals, have in our bowels, and many babies have it. The problem, and it doesn't create any problems. The problem is when it takes over for the other bacteria that are usually in the healthy gastrointestinal tract. And that is usually for patients who have received antibiotics for other diseases, such as your ordinary urinary tract infection or pneumonia or other diseases that need to be treated with antibiotics. The problem with antibiotics is that not only kills the bugs that you would like to kill, but it kills a lot of other bugs as well, healthy bugs that all of us have in our intestines. And when that happens, and the antibiotics you take for a good reason, sometimes this bug, C. diff, takes over the entire large bowel. There's hardly anything else there than this one bug, and that creates the problems, that creates the symptoms for these patients, which are heavy diarrhea. It can be fever, abdominal cramps, and some of these patients are getting very, very sick. Now, we have about 500,000 of these infections, C. diff infections, in the United States every year, and about 25,000 patients die from a C. diff infection each year in this country. So it's quite a significant problem.
Dr. Brett Hauer, in the United States, the Food and Drug Administration allows these fecal transplants, and professional societies endorse them, but only as a last resort. In other words, first you have to treat with antibiotics, and maybe not just one course, but maybe several courses. And then if nothing else works, the FDA says, well, okay, now you can try a fecal transplant. You did an experiment, and it's been published in the New England Journal of Medicine. Can you share what you did and why it might change the paradigm and maybe revolutionize the treatment of C. diff?
So for me, this all started in 2013 when another paper came out in the same journal, the New England Journal of Medicine, describing what you just described, which is the treatment of what we call recurrent disease with fecal transplants. So patients who are getting the disease, then getting treated with antibiotics, which is or has been the standard of care for these patients. So treating them with another antibiotic who kills that bug, C. diff. And most of these patients get well, but about 25 or 30% get a recurrence. So after a couple of weeks or months, they again develop symptoms of the disease, so the bug is back and they need another treatment. And as you say, as a last resort for these patients who have disease recurrence, after the study from the Netherlands in 2013, where they tried to use feces for these patients, and it worked very, very nicely. After that, people in this country and in other countries started to use fecal transplant as a last resort for these patients who don't get well on antibiotics. Now, I was thinking at the time, this is very interesting. I was very excited about it, and I used that in my clinic over there in Norway. But I was thinking, well, you know, if it helps for the people with the recurrent disease, so the people who get the disease back after they're well, I would be very interesting to know if it also helps if you just start with it. So giving it right at the start of the disease, the first time you get it, instead of antibiotics. Because as we all know, antibiotics, they work very well in most patients, but they have considerable downsides related to its use. There is, of course, the big problem of antibiotic resistance that we talk about all the time. Bugs are getting resistant to antibiotics, and that is an increasing problem because we use more antibiotics. And the other thing with antibiotics is that people are getting side effects. And lastly, of course, antibiotics are expensive. They're costly. So I was thinking, what if feces helps not only the patients with recurrent disease, but also all the other patients who get this disease the first time? So we talked about this in our research group in Norway, and we decided to set up a clinical trial testing this hypothesis that fecal transplant also would work instead of antibiotics for all the other people who don't have recurrent disease. So we did a small study, and that's what you usually do when you have a hypothesis, but not more than that. And of course, a lot of people were skeptic about it, but you set up a small clinical trial. You ask patients with the disease to volunteer to participate in the trial, and that's what we did. And so what we did is that we took 20 patients at 6 Norwegian hospitals between 2014 and 2015, and asked them, and these were all patients who had their first episode of C. diff infection, so they had never had it before, and then they got sick with their diarrhea, and we discovered that they had C. diff. We asked them to be part of the study where we either treated them with feces or with antibiotics, and antibiotics is the standard. 9 of the patients were treated with feces, and 11 patients were treated with antibiotics, and the results were that the feces was at least as good to get rid of the disease as was the antibiotics. It was actually a little better, the feces, as compared to the standard treatment, the antibiotics, but the study was small, only 20 patients, so it did not reach what we call statistical significance. But the take-home message from the trial is that feces or fecal transplant may work not only for recurrent patients with C. diff colitis, but for all patients.
Dr. Bredhauer, your study is very exciting, but as you point out, it's essentially a proof of concept that C. diff could be treated with fecal transplant rather than antibiotics. It might be just as good and perhaps in some ways better. Do you imagine that further studies will be done to confirm the results?
Yes, as you say, this is a small study, 20 patients, and it is not what we call definitive. So it is not a study where I would say today that everybody should just go out and start treating these patients with feces. There needs to be at least one, hopefully several larger studies to confirm the results that we obtained in this small study. And we are right now ourselves in my research group over in Norway and in Scandinavia planning this follow-up trial with about 200 patients, which will start just in a couple of weeks or in a month maybe, we hope, to try to confirm what we showed in the small trial.
Dr. Bredhauer, I suspect a lot of your colleagues are a little worried about the quality of the transplants, shall we say, because one doesn't want to cause harm. How do you make sure that the material that you're using in these transplants is safe and not going to give patients perhaps some other condition or disease that might be as bad or worse than what they're trying to treat?
Well, that is a very important question. And of course, we used a commercially available product from a Swedish provider for this particular trial. And that product actually is not contained of fresh feces, but it is contained of feces that was collected about 20 years ago. And the bacteria in this feces have been in the lab for over 20 years before we used it for the current trial. And during this period of time, of course, these bacteria, they were growing in the lab, and the company does a lot of testing to ensure that there are no either bacteria or viruses or any other substance in there which should not be there, may harm patients. So the safety side of this is very, very important. Having said that, there may be something in feces which we have not discovered yet, and that may cause disease for people in the future. I think personally it is unlikely, but I cannot, of course, exclude it. Nobody can do that. So there may be things in feces which we don't know yet and which may cause disease. This is something that is an inherent risk with all of these fecal-based therapies. Again, I think the absolute risk is very small, but nobody knows if there is a real risk and how large it is.
At this point, in the United States, fecal transplant can be used only as a last resort and only for C. diff infections. Do you anticipate that this approach might be useful for other types of conditions?
There's a lot of research going on to apply fecal transplant for other diseases than C. diff. C. diff has been the first one where this has been tested successfully. It is the most logical one because the disease is caused by disturbance in the gut flora, which is then reestablished by feces very easily, as the research shows. But people are now testing fecal transplant for a number of diseases, and some of them are bowel diseases, and I think most of the research which has been done has been in either inflammatory bowel disease, so this is ulcerative colitis and Crohn's disease, and in irritable bowel syndrome, which is of course very prevalent in the Western world. The results so far, I would say, are mixed. They're not as impressive as there are with C. diff colitis. There are some negative studies and some positive studies. There's still a lot more research to do to find out if there is a role for fecal transplant in other diseases than C. diff colitis.
I'm curious if there are other conditions that might benefit from fecal transplant beyond the digestive tract issues such as ulcerative colitis. Anything on the horizon?
Well, one big thing people are talking about is treatment of obesity, which is, of course, a major health problem in this country and other countries. So treatment of obesity by altering the microbiome of patients who are overweight. And there has been a lot of basic science research about that with mice where one has changed the microbiome and has seen that weight is changing in these mice compared to mice who did not have a change in their microbiome. This is very interesting and very exciting research, but still at a very, very early stage, I would say. I know that some people have started clinical trials with patients, although I don't know all the details in it, but it's far too early to say if there is any role of I would say microbiome treatment, not necessarily feces and not necessarily fresh feces, in conditions like obesity or chronic fatigue, multiple sclerosis. All these diseases have been mentioned, and people doing animal research on it.
Dr. Michael Breithauer, thank you very much for talking with us on the People's Pharmacy today.
Thank you so much. It was great to be here.
You've been listening to Dr. Michael Breithauer. He's professor of medicine at the Institute of Health and Society at the University of Oslo and the Department of Transplantation Medicine in Oslo University Hospital, Oslo, Norway. He's also president of the Frontier Science Foundation in Brookline, Massachusetts.
And if you are interested in stool transplants to treat C. diff infections, we did an entire show about it several years ago. Look for show number 935 at peoplespharmacy.com.
We also spoke earlier with Dr. Nicholas Shaheen, the Bozimsky-Heiser Distinguished Professor of Medicine at the University of North Carolina School of Medicine. He's chief of the Division of Gastroenterology and Hepatology.
Lynn Siegel produced today's show. Al Wadarski engineered. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is brought to you in part by BrainGauge, developed by neuroscientists at the University of North Carolina to track brain health. Home, research, and clinical applications available. Home subscription options are available online. GaugeYourBrain.com.
If you would like to buy a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1144. That number again, 800-732-2334, or find it online at peoplespharmacy.com.
When you visit our site, you can share your thoughts about today's show. Have you had a colonoscopy in the last 10 years? If not, why not? Are you concerned about Barrett's esophagus? Have you ever had a bout of C. diff diarrhea? How did you get over it? Please share your story in the comment section for today's show.
At peoplespharmacy.com, you can also sign up for our free online newsletter or subscribe to the free podcast of the show. When you sign up for the newsletter, you'll get our free e-guide to favorite home remedies.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening. Please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to the People's Pharmacy.